Gastrointestinal surgery is some of the most difficult surgery I perform as a general surgeon. It's not because it's technically challenging, but it's because of the risks that it poses to you, the patient. There are several reasons why we may need to enter your belly and operate on your GI tract. We may be going into your abdomen to explore an abnormality seen on an x-ray, to remove a segment of stomach, small bowel, or colon for cancer, or to unravel a bowel obstruction or blockage. Regardless of the reason, it is a decision not to be taken lightly, and your surgeon should explain in detail the indication in your particular case. Whether or not it was initially planned, it is important to understand that removal of a portion of your gastrointestinal tract is necessary in these situations. This requires rerouting and reconnecting your intestines so that food can get from the top to the bottom as before. Ultimately, all stomach, small bowel, and colon surgery is based upon the same general concepts. This video is going to discuss the most common pre- and post-operative concerns specific to your surgery. In addition to this video, I insist that you also watch the video titled General Surgery Expectations for key information that applies to all types of surgery. Depending on the type of bowel surgery you are having, you may or may not require a clean out of your intestine. If you think about it, it makes sense that operating on your intestine is less complicated if there's no solid material inside. In all cases, you will not have anything to eat after midnight the night before your operation. The further the distance of the operation from your stomach, the more likely it is that you are required to be on a liquid diet the day prior to your operation as well. If the operation is in your colon, a bowel preparation or flush out, enema, and antibiotics will also likely be included. Specific instructions will be given prior to your surgery. If not, now is a good time to ask your surgeon just in case that information was somehow lost. Other requirements prior to surgery include the following. Shower the night before or morning of surgery as you would normally. Be sure to clean out your belly button as one of your incisions will most likely go right through it. Pack a bag with your basic needs. Think everything through at least a week in advance if possible. It will be difficult and unrealistic to get questions answered after hours the night before surgery. It is important that you take as much ownership of your care as possible. This will help you understand the process better and minimize confusion throughout your hospitalization. Ultimately, although everything may be new to you, these are operations that have been performed for years with well-established methods and outcomes. You can expect top quality care in all situations. You're probably wondering how long you will be in the hospital. Intestinal surgery is different than routine hernia repairs, gallbladder removals, and skin operations that are performed as outpatient surgeries. Nearly every case requires at least one day in the hospital, but this can last as long as a week. Just as described in the General Surgery Expectations video, you will need to plan accordingly for a short hospitalization and bring some basic items to satisfy your needs. If you presented from the emergency room, you may not have that luxury. But don't worry, the hospital will provide everything you absolutely need. You will arrive for surgery at the previously scheduled time. This is typically 2 to 3 hours prior to your actual surgery. After all the preparations are made, you will leave your family to the waiting room as you are taken off to the operating room. You will be admitted to the hospital after your surgery. After surgery, you will spend time in the recovery room until you are stable enough for transfer to your hospital bed. Very often, you will not reunite with your family until transfer to that hospital bed. They will be updated on your progress until that time. Once you are settled into your hospital room, recovery begins. There are several key components to a quick, effective recovery: mobilization and activity, pain control, and most important, return of bowel function. You will get out of bed with assistance the same evening your surgery was performed. This is unless your surgery was not complete until late in the day. In this case, you will get up first thing the next morning. Movement as soon as possible after your surgery is the most important thing you can possibly do to accelerate your recovery. Reduce your risk of complications such as blood clots in your legs, and believe it or not, reduce your pain long term. From a pain control standpoint, you will be given a combination of local medication injected near the incision to block your pain during the operation, anti-inflammatory medication in your IV or by mouth, medication to reduce muscle spasms, and IV narcotic medication at your request based upon a schedule provided to the nurses by your surgeon. You may be given a machine that delivers narcotic pain medication when you hit a button as well. These are less commonly used as narcotic pain medicine actually slows your recovery fairly dramatically and should only be used as a last option. An abdominal binder may also be provided. They can really help support your stomach and reduce the need for pain medicine. If you know you are having surgery, you can pick one of these up at the pharmacy or sports store beforehand for a better price. The most nebulous or difficult to grasp part of intestinal surgery is the return of bowel function. In order for food to pass from your mouth onward, a special type of muscular movement called peristalsis must occur. After surgery on your stomach, bowel, or colon, this muscular movement is paralyzed for a period of time. This is called an ileus. Your intestine moves in a similar fashion to the way a caterpillar crawls. Normally this happens naturally and you don't even have to think about it. One of the most consistent indicators of a normal bowel function is the passage of gas. The average person passes flatus 14 times a day. The majority of this gas is actually swallowed with saliva, particularly while talking. Even if you haven't eaten anything, you will pass gas once your bowel function has returned. Burping, hiccups, and a feeling of fullness is exactly the opposite. These are clues that your intestine is not ready to move things through yet. This is a critical time after surgery that is often difficult to understand. The most frustrating part is how little we can control this situation, and we must take whatever advantages there are available to us. Again, an important thing to keep in mind: any narcotic pain medication you receive will slow the progress of your intestinal function returning to normal. Return of bowel function, which is usually signaled first by passage of gas, can occur any time from 1 day to 3 weeks after surgery. Typically, larger, more complicated operations and diagnoses result in longer wait times. Typical times for return of bowel function after surgery are as follows: left colon and rectum resections, 1 to 3 days. Right colon resection, 2 to 5 days. Small bowel resection, 2 to 5 days. Stomach surgery, 2 to 7 days. Bowel obstruction surgery, 2 to 14 days. Diverticulitis surgery, 2 to 14 days. Perforated appendicitis, 2 to 14 days. Crohn's disease surgery, also 2 to 14 days. While we are waiting for your bowel function to return, you may not be allowed to have anything to drink at all. But more commonly, you will be allowed sips of clear liquids for comfort. You will have to pay close attention to your body's signals. If you feel full, nauseated, or burping, have the hiccups, or simply just aren't hungry or thirsty, don't eat or drink. Pay attention to your body. It will be the best indicator of when you're ready to move forward, and only you will be able to tell. We will rely heavy on your interpretation of these symptoms. When you first start to pass gas again, it means your gut is ready to move things through, but it will do so very slowly at first. It usually takes a few weeks before things completely normalize, so you will have to listen to the cues your body gives you going forward. Since your appetite will be limited at first, focus on hydration followed by quality calories. This means water and a protein supplement. Any brand or type is acceptable, and there is no way to make a mistake from this standpoint. Once you begin to have more of an appetite, it's okay to try other foods. It's a good idea to stick to a low residue diet for the first 1 to 2 weeks. This basically means you should avoid fiber, and it may be the opposite of what you would expect. There are plenty of simple to follow resources available online that describe a low residue diet. Lastly, you will need to prevent constipation. While stool softeners are effective, they generally fall short with a surgery of this magnitude. I recommend taking Miralax daily for prevention during the entire time you are taking narcotics or until your first bowel movement. If you are having loose bowel movements, cut your dose in half. If it seems to be ineffective, double your dose for 3 days. Call your surgeon if you are unsure or unsuccessful. Your first bowel movement will likely be at home. If you have had any type of anastomosis, you should expect to have at least one bowel movement with dark red blood in it. There may be more than what you expect, and it is not uncommon to have more than one. Nonetheless, call your surgeon if it is bright red, or if you are unsure in any way. In some cases, a colostomy or ileostomy may be formed. An ostomy is a diversion of your fecal stream to the surface of your belly. These are performed when the rest of your intestine is unfit to have stool running through it. It would be exceptionally uncommon for this to occur without prior discussion before surgery. In most cases, it is not planned, but a possibility, and your surgeon will discuss the probability of that occurring with you prior to surgery. Common diagnoses or situations where you could end up with an ostomy include an emergent intestinal surgery, bowel obstructions or blockages, diverticulitis, inflammatory bowel disease such as Crohn's or ulcerative colitis, and cancer. Prior to going home with a colostomy, you will have to learn how to care for it. This will include washing and fitting an appliance to it to catch everything that comes out. Don't worry, you will be able to go out in public again and hide it from view. Generally speaking, when a colostomy is formed, the intention is to reverse it one day. This is usually performed after the primary process that started your condition has completely resolved. A typical time frame can be as little as 6 weeks or as long as a year. Discuss this with your surgeon, who will tailor a specific plan for your case. In order to go home, you will need to meet certain criteria. You will need to pass gas consistently and tolerate at minimum enough liquids to stay hydrated. You will not need to have a bowel movement prior to leaving the hospital most of the time. You will need to tolerate pain with medications in pill form only, and be able to perform basic functions at home in order to care for yourself with limited assistance. The faster you transition home, the quicker your recovery will be. Remaining in the hospital beyond what is necessary will potentially compromise your health and put you at risk for infection, blood clots, and other risks commonly associated with prolonged hospital stays. We will constantly assess your situation and weigh the risks and benefits of discharge on an individual basis. Our biggest concern is always your safety. As with any type of surgery, it is reasonable to expect some amount of pain. This varies with individual patients and depends on your body's response to pain medication. Narcotic pain medication will always be your last option for pain management. Pain control will focus on non-narcotic medications and maneuvers first. This will result in the quickest return to normal. Abdominal binders, an elastic wrap around your belly, are a great start. They support your abdomen and effectively reduce the amount of pain medication you will require. In most cases, the hospital will provide one, but they are available online if you would like to come prepared. The next step in pain control is the use of acetaminophen, Tylenol, and non-steroidal anti-inflammatory drugs such as ibuprofen or naproxen. Typically, acetaminophen is scheduled every 6 hours and alternated with your choice of ibuprofen every 8 hours or naproxen every 12 hours, but not both. In some instances, there are certain conditions that prevent you from being able to take these medications. Your physician will cover these issues if they apply to you. After the non-narcotic options have been exhausted, it is okay to move forward with more aggressive pain management options. The first focus will be on muscle relaxation. A typical response to our pain in your belly is tightening of the muscles, which can exacerbate your pain. An option for this may include prescription muscle relaxers such as diazepam. Lastly, narcotic pain medication will be provided with or without acetaminophen or Tylenol. A common choice will be oxycodone, which can be taken every 4 hours for severe pain not controlled by anything else. This is a highly addictive pain medication that will slow your bowel function significantly and commonly causes severe constipation. Please only use it with the most severe pain unresolved by anything else. See the General Surgery Expectations video for more recommendations on pain control. In most cases, it will take 6 weeks before you're able to consider yourself completely back to normal. You'll be able to resume the grand majority of your routine activities much sooner, however. It is common to start the day doing well, but simply run out of energy early in the day. Overall, it is best to do as much as you can within reason to facilitate normalization. The first day back to work always feels like the first day back to work, whether it is 2 weeks or 6 weeks after surgery. Motivated patients always recover the most quickly. Most patients feel strong enough to return to work in 3 to 4 weeks following the operation. Some patients may return sooner if they do desk work or work from home. If you do work that requires you to lift greater than 20 or 30 pounds, bend, or reach, then you may need to be placed on restricted work duty until you have your last post-operative appointment, usually about 6 weeks after surgery. If you need a letter or work excuse to be sent to your employer, please let your surgeon or nurse know before the day of surgery. You may resume sexual relations when it feels comfortable to you. Generally speaking, there will be no restrictions after 6 weeks. The likelihood of you affecting the surgery is very low, but the chance of surgical sites will affect you from a pain standpoint is high. And as a general rule, if it hurts, don't do it for the first few weeks. Pay attention to the next section of this video as it describes the most common risks and complications with intestinal surgery. Most of the time, these are situations out of our control, and it's important that we recognize them as soon as possible if they occur. If any should happen to you, you will want to be well informed. Everyone's biggest concerns, including mine, are the what-ifs. This list is by no means exhaustive, but it certainly covers the grand majority of issues that could come up with your surgery. Regardless of the outcome, Know that you will be treated the way I would want to be treated in every case. Wound infection. These are usually superficial or on the surface and can be treated by draining the site. Special protocols are used with intestinal surgery to prevent wound infections, but they still occur a certain amount of the time regardless. The intestines are not a clean, bacteria-free organ. The biggest risk factors are obesity and smoking. Deep abdominal space infections or abscesses are only common when the reason we entered the belly in the first place was an emergency or serious infection already. They can also occur when a connection between one piece of intestine to another, called an anastomosis, fails to heal properly. Major bleeding can happen with any operation. Every step will be taken to ensure that this does not take place. Here are the risks of a blood transfusion if necessary. We do not perform them unless absolutely required. Possible conversion to an open operation can mean a larger incision than expected and extended hospital admission, and you will be informed beforehand if that is the case. Another potential issue is a hernia. A hernia is a protrusion of tissue through the weak spot in your incision. Hernias are more common with emergency surgeries, but they do occur with routine operations as well. The risk is much higher if you are obese or have a history of smoking. An operation is necessary to repair a hernia, and this is usually performed after you recover from the primary issue. Gastrointestinal tract issue from a leak or anastomosis can be a serious complication that, if missed, could be life-threatening. Immediate intraoperative repair would follow. When attaching one part of the intestinal tract to another, the complication with the greatest potential to do harm is a leak. I can do everything necessary and perfectly to perform a connection mechanically, but ultimately anastomotic leakage is dependent upon healing. Certain things such as unplanned or excessive weight loss, malnutrition, smoking, congestive heart failure, and preoperative steroid use are known to affect healing and increase the leak rate. These same factors contribute to hernia formation, which is also dependent upon healing. Leak rates vary on site. Here are some examples. An excellent tool to calculate your own risk for surgery is as follows. Go to the website and enter your information to see your estimated risk for surgery if desired.